All right, today's lecture is going to focus on acute renal failure, otherwise known as acute kidney injury. Now, in acute kidney injury, you have a rapid loss of kidney function. So that is the main idea regarding this lecture today. So again, remember, it is a rapid loss of kidney function. Now, in acute renal failure, this may be reversible, and we'll look at some of the causes. We're going to focus on prerenal, intrarenal, and postrenal failure. So let's talk about prerenal failure first. So here I have, kind of looks like a strawberry, but this is the heart. Very, very simple drawing, okay? So here we have the heart. We have the aortic arch, the descending aorta. Remember, it's going to come to a point where the renal arteries will then supply the kidneys. So here we have our kidney. So let's focus on prerenal failure. So in prerenal failure, the cause is due to, number one, decreased cardiac output or decreased blood volume. Or it can also be due to some type of occlusion. So let's break this down, okay? Prerenal, meaning before the kidneys. The cause is before the kidneys. Remember that, for example, the heart is going to, the left ventricle is going to pump blood into the aorta. Blood is going to get pumped down. It's going to go into the renal arteries. The renal arteries are going to supply blood to the kidneys. Now, let's say that this patient has heart failure. Or maybe this patient suffered from an MI, myocardial infarction, had a heart attack. Now, the heart isn't able to contract, it's not able to pump like it should. Therefore, there will be decreased cardiac output, meaning there will be a decreased amount of blood supply throughout the body. We've talked about how, for example, if you have decreased blood supply to the brain, you'll end up with something like a stroke, because the brain requires a large amount of blood supply. It needs that blood supply. If the amount of blood is decreased to the heart, you could end up with something like an MI, a heart attack. If, however, the amount of blood supply is decreased to the kidneys, then you could end up with acute renal failure. So again, we have decreased cardiac output. We have a decreased amount of blood supply, in this case, to the kidneys. Now, another reason for this could be hypotension. Low blood pressure. Again, the result is the same. You have a decreased amount of blood supply to the kidneys. Okay, that is why it is prerenal. The problem is occurring before the kidneys. In this scenario, we have the heart maybe not pumping like it should because the patient had an MI. Maybe they have a history of heart failure, and again, the heart is not able to pump like it should. Therefore, they will have decreased cardiac output. Maybe they are extremely hypotensive. An example of this would be, for example, the patient may have had some type of trauma. They're bleeding out large amounts of blood. So we have here decreased blood volume. Another scenario that may cause decreased blood volume may be dehydration. Maybe this is an athlete who's been in the sun for too long, has been sweating a lot of fluid, sweating a lot of sweat, losing blood volume due to fluid loss. The result will be hypotension, and again, not enough blood supply to the kidneys. Now, another reason may be something like an occlusion. Let's say that this patient had problems, for example, like AFib. Now, we know that, for example, in AFib, there is the likelihood of clot formation. Well, what would happen if one of those clots traveled down and occluded the renal artery? Well, then again, no blood supply can go to the kidney, and as a result, renal failure or acute kidney injury may result. Now, we just got done talking about our lectures on aortic aneurysm, aortic dissection. Again, if you have a aneurysm rupture, you would end up with decrease in blood volume. Same thing, if you have a dissection, we talked about how maybe blood will come in here, will pull in here. Two things may occur. Clot formation may occur. This clot may come back in and again cause an occlusion like we just talked about. Or number two, since you have blood pulling in here, you have decreased amount of blood going to other parts of the body. In this case, the kidneys, again causing renal injury, acute renal injury. So this is pre-renal. Again, the problem is becoming or occurs before the kidneys. So now let's get into intrarenal failure. Intrarenal failure means inside the kidney, so the actual kidney is being damaged. And in this case, we are concerned with two things: the glomeruli or glomerulus, and number two, tubular damage, or the tubules becoming damaged. In glomerular damage, we worry about something called glomerulonephritis. Okay, glomerulonephritis, inflammation of the glomeruli. That's all glomerulonephritis means. Again, inflammation of the glomeruli. Now, typically, what causes this inflammation is an infection, mostly caused by strep infection. So again, we've had a lecture on other causes or other problems regarding strep, how if it affects the throat, spreads, it can affect the heart. Well, it can also come to the kidneys and cause damage. Okay, so that could be a reason for glomerulonephritis. Another cause could be something like CMV, cytomegalovirus. Now, if the tubules are damaged, you end up with acute tubular necrosis. Now, this is the most common form of intrarenal failure. Again, acute tubular necrosis. And in acute tubular necrosis, the cause for this is ischemia. Again, decreased blood supply. So if you have ischemia, you have less blood supply to the kidney, meaning less oxygen supply, which again causes damage, in this case to the tubules of the kidney. Now, there are other things that can cause tubular damage. So let's focus on these a little more closely. Drugs, medications, drugs that you need to know. For example, gentamicin. Vancomycin. When you give vancomycin, you always have to check the levels. Because again, if you're giving too much, you can cause renal damage. So you always want to check your vanc levels. Make sure you're not giving too much. And also you want to make sure that you're giving enough. If you're not giving enough, you're not reaching that therapeutic level. So when you're giving vancomycin, gentamicin, again, you always want to look at your levels. If they are high, you want to inform the physician immediately. You do not want to cause damage, permanent damage to those kidneys. Another drug that may cause intrarenal failure may be something like IV contrast. Iodine. Is this patient getting a CT done? Is this patient diabetic? Is this patient diabetic on diabetic medications and getting IV contrast? If so, you may put the patient at risk for suffering from acute kidney injury. So you want to make sure you have a detailed history on your patient. You want to make sure that you know what medications they're on. You may also see this on the nclex MRI contrast. That is something known as gadolinium. This can also cause renal damage. So make sure you know of iodine contrast. That is if they're going to get something like a CT, maybe some type of catheter put in place, or if they're going to have an MRI done and they require gadolinium. Other medications that can cause problems are your NSAIDs. Blood transfusions. Can also cause problems to your kidneys. Let's talk about another one here. We have hemolysis, or ruptured red blood cells, or maybe even ruptured muscle cells. So you have maybe myoglobin ruptured into the bloodstream, or released into the bloodstream due to, again, those cells rupturing. So hemolysis, or a lot of myoglobin in circulation. Now, how can you remember this? Well, let me give you this example. A couple of months back, my brother was changing a air conditioning unit. Now, he made the mistake of not completely turning off all power supply to the building where he was working on. Now, when he went to go plug in the air conditioning unit, he got severely shocked. It actually knocked him out. Nothing was wrong with him. He just passed out for a little bit, came back, he was fine. He had a lot of bruising on his face, on his arm from where the shock occurred. He was fine, no problems. But the ER physician told us to watch out for his urine output, to watch for the color of his urine, because if his urine became severely concentrated, if his urine output decreased, it may be a sign that his kidneys were damaged. Well, the question was, why would the kidneys be damaged? Well, since he had that severe shock, that could have caused lysis, or rupture of some of his blood cells, some of his muscles. In that scenario, he would have had large amounts of myoglobin in circulation. Myoglobin will come to the kidneys, and they may occlude the tubules, causing damage to the kidneys. Okay, so remember that for your nclex exam. Again, hemolysis, or large amounts of myoglobin in the blood. So if this patient had some type of trauma, a lot of cells rupturing, again, this could cause intrarenal failure. So we've talked about prerenal, the cause being before; intrarenal, the cause being inside of the kidneys. Now we must focus on postrenal. So let's draw another picture here. So we talked about our heart. We have our aorta. We have our renal arteries, our kidneys, and also remember that your urine is going to be excreted. But first, you must go through your ureters, right? And your ureters are going to come down and connect to your bladder, where it will collect until you void. So in post-renal failure, we worry about, for example, it's right here, post, we worry about a couple of things. Renal calculi, or renal stones, kidney stones. Number one. Number two, we worry about, in men, BPH, benign prostatic hypertrophy. Maybe prostate CA. So let's talk about these here. Now, renal stones can occur in both men and women. So again, you have kidney stones. Sometimes they are small enough to where they come down and then boom, they cause an occlusion there. Now what ends up happening is, again, your kidney's still producing urine. Urine can no longer flow down to your bladder. Instead, it begins to accumulate. Adding pressure, urine will actually fill the kidney, and eventually what you will see on CT is leakage of fluid out of the kidney. Okay? And it's urine, waste product. So this too can cause damage to the kidney, but this is occurring after the kidney. This is occurring in the ureter. For that reason, it is called post-renal failure. Okay, it is happening after the kidney. Now in men, remember, you have to worry about the prostate, because if it enlarges, it can cause compression. Same thing happening. Urine cannot get out. Patient has difficulty voiding, so the bladder gets larger, and the same thing happens. Urine goes up the ureters, and the same thing happens. Urine begins to accumulate in the kidney and begins to spill out. End result is renal damage. Same thing with prostate CA. So we briefly talked about pre, intra, and post. So now let's focus on some clinical manifestations. Number one, decreased urine output. Now again, this will typically be determined by exactly where the problem is occurring. For example, we talked about in pre-renal failure how you have decreased cardiac output, maybe decreased blood volume. So if the patient is losing large amounts of blood, let's say that the patient had some type of trauma, maybe some type of stab injury. If the patient is losing blood, or if the patient does not have enough blood supply to begin with, what's going to happen? Well, the kidneys are not going to produce any urine, because again, they're going to try to conserve fluid to maintain adequate blood pressure. Therefore, again, here you will have a decreased urine output. If, for example, you gave this patient vancomycin today, tomorrow, and you did not notice that these levels were causing damage to the kidneys, well, you may not see the full effect of that damage for several days. So there may be some urine output, but throughout time, urine output will decrease. If, for example, the problem is post-renal, maybe the patient has BPH, well, they have the urge to void, but they can't because there's some type of occlusion there. So again, decreased urine output occurs. Now, what you want to watch out for is a urine output of less than 400 ml cc's per day. Now again, this will depend on where the pathology is occurring, because in 50% of the cases there may not be a significant amount of decreased urine output. Just like I talked about, if you're giving vancomycin and it's in high levels, you may not get the full effect until several days after you've caused damage to the kidneys. Number two, if you were to do a UA, you would find that there are casts in the urine. So this is a big one. If you see on the nclex exam casts in urine, that should let you know that there's some type of renal injury, acute renal injury, renal failure occurring. Okay, so again, casts in the UA, along with RBCs and WBCs. You may also find some protein in the urine, or proteinuria. If you do a specific gravity, you'll find that the specific gravity is at 1.010. If you do a urine osmolality, again, this is urine osmolality, it'll be 300 millimole per kilogram. So those are your findings in the UA. Number three, you will notice that there is neck vein distension. Now why? Well, we talked about how, again, your kidneys are filtering your blood, they're producing urine. Well, if you damage your kidneys, you've damaged that ability to filter your blood. You've damaged that ability to produce urine. Therefore, again, if you're not having any urine output, you're going to become to accumulate all that fluid. That fluid accumulation will cause this neck vein distension with a bounding pulse. Because again, you're not getting rid of any fluid. As a result, you will also have peripheral edema, pulmonary edema, hypertension, again, because you're accumulating large amounts of fluid. So you'll have fluid overload. Now, it is at this point that we begin to worry about heart failure. If this fluid accumulation continues to occur, then you may end up with something like pericarditis. Which is again that inflammation, that pericardial sac becomes inflamed. That is pericarditis. Now again, if you have fluid accumulating in that area, you will end up with cardiac tamponade. Number 4, metabolic acidosis. Again, remember, your kidneys are going to be filtering your blood. They're going to be getting rid of waste products, getting rid of acid products. So if you damage that, you're going to be accumulating all these wastes and all of these acids. So if you were to do an ABG also, you'd find increased levels of hydrogen ions with decreased serum bicarb levels. This will again add to the acidosis occurring. Now, because the patient is undergoing metabolic acidosis, that patient will most likely begin to perform Kussmaul's respirations. So rapid breathing, deep rapid breathing, again, they're going to try to blow off CO2 to decrease this acidosis. Number 5, you'll have sodium loss because the kidney will not be able to retain sodium due to that damage. Now, if we have severe sodium loss, remember that you'll end up with hyponatremia. And if we have hyponatremia, one of the complications that we must worry about is cerebral edema. So here we want to assess for any altered mental status, any headaches. Because again, if the brain is beginning to swell, most likely headaches will occur. Again, if the cerebral edema is not fixed, if you do not take care of this problem, the patient will suffer from seizures. In this scenario, you would always institute seizure precautions. Make sure they're lying on their sides, because you always worry about aspiration if seizures were to occur. Number 6, high or increased potassium levels. Again, this is due to your kidneys being unable to excrete potassium. Now also remember that when you have an acidotic state, it will also cause potassium levels to go up. So number 1, your kidneys can't excrete potassium, your levels of potassium are going up, and number 2, acidosis is occurring, which is further causing potassium increases. Now remember that we always worry about our potassium levels being very, very high because it will affect how the heart functions. So in these patients, you want to get an EKG or hook them up to telemetry. You want to make sure that you're assessing any chest pain. You want to report that to the physician immediately. Number 7, if you were to do a BMP, basic metabolic panel, you'd find that BUN and creatinine levels are elevated. So you'd have high BUN, high creatinine, and a decreased GFR, less than 60. GFR stands for glomerular filtration rate. Okay, again, glomerular filtration rate. So your glomeruli are filtering. Well, in this case, we talked about how you're going to have renal damage. Most likely, your glomeruli will not be filtering. So this number will be low. Number 8, altered mental status. And we talked about how you would have that due to this cerebral edema. Again, you're always going to be watching out or monitoring for seizures. And not only this, or hyponatremia, is that what's going to be causing the altered mental status, but remember also you're going to have changes with the pleural edema. If there's some pericarditis, if there's cardiac tamponade, that is also going to further cause decreased cardiac output. If you have more, or if you have if you have decreased cardiac output, if that begins to worsen, then again, you're not having that blood supply that the brain needs. So that will also cause altered mental status. Now, what are some diagnostic studies? And I've already mentioned a couple of these, so we will just briefly talk about our diagnostic studies. Number 1, If a renal stone is suspected, or maybe BPH is suspected, a CT may be done. Again, that would typically be done to rule out kidney stones, maybe some type of prostate problem. Number 2, your BMP, basic metabolic panel. And here you will always monitor your BUN, your creatinine, your GFR, your sodium and potassium levels. You want to make sure that you know what your electrolyte levels are. Number 3, ABG. Number 4, UA. Now, what are some interventions for these patients? Number 1, first, hopefully, you treat the cause. So again, the intervention will depend on the cause. If there's a hemorrhage, then you'd want to stop the hemorrhage. Because again, if you take control of the hemorrhage and if you provide adequate fluids, then again, you can return that blood flow to those kidneys right away. If, for example, you're giving vancomycin, gentamicin, then you would want to stop that antibiotic therapy, let the kidneys heal. If, for example, the patient was given something like IV contrast, iodine, then the physician may elect to hydrate that patient. They may say give the patient a bolus of IV fluids. So first is determining and treating the cause. If the cause is a renal stone, well, then the patient may undergo some type of lithotripsy, maybe stone removal, maybe a stent placement. So again, first is treating the cause. Number 2, possibly some diuretic therapy. So patient may be given something like Lasix, Bumix, or mannitol. Now again, Lasix, you remember not to give this IV push. It may cause ear damage, hearing loss. Okay? Now again, diuretic therapy will be determined by the physician. And again, it depends on what the cause of the renal failure is. Number 3, fluid restriction. Why? Number 4, sodium restriction. But why? Well, we talked about how you're retaining large amounts of fluid, which can cause fluid overload. So if the potential for fluid overload exists, you will want to restrict the amount of fluid intake. We talked about how there might be some hyponatremia, but still you must restrict the amount of sodium that you give. Again, this will be determined by the physician. They will inform you as to how much sodium to give, because again, you're retaining fluid. If you were to give large amounts of sodium, you're only going to cause an increase in blood pressure. So again, you want to restrict, you want to monitor the sodium intake very, very closely. Number 5, you want to control potassium levels. Now you can do this by different forms, different mechanisms, different ways. You can give insulin and sodium bicarb. is one option. Then give calcium gluconate. Or you can give something like Kayexalate. Now this will remove potassium from the body. However, you will never give Kayexalate to a patient that has a paralytic ileus. Excuse me. Okay, so make sure you know that. So if you see Kayexalate on your nclex, I've seen this on a lot of practice questions. Again, Kayexalate is to bring down potassium levels. But you will never give Kayexalate to patients that have a paralytic ileus. If these interventions do not correct a problem, then the physician may opt for something like dialysis.